Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
This case is a 68-year-old man who presented to the emergency department with a 3-day history of worsening right knee pain and swelling of the right knee. He is now struggling to weight bear secondary to pain. He doesn't report any trauma recently to that knee, and he's been feeling a bit tired over the last week, but denies any fevers. He's type 2 diabetic, takes metformin 3 times a day, but that's his only medication. He's got no known drug allergies. He's a retired security guard who lives with his wife.
Has he done any unusual activities recently?
No, not really, just doing a bit of housework, nothing that he can sort of pinpoint.
So has he been on his knees a lot, working on his knees, basically sort of roughing up the front of his knees?
No, he didn't report anything like that.
Besides having diabetes, has he got any other kind of immunosuppression?
No. He doesn't report any sickle cell trait.
Any previous surgery on this knee?
No previous surgery on that knee, no.
So no metal work in there?
No.
What did you find on examination?
There's a nice photo here that shows he's got a very swollen right knee. There's no broken skin or skin changes to that knee. It is hot to touch and is tender globally. He's sort of holding the knee at about sort of 5 degrees of flexion, trying to support the leg because it's quite painful. There's a large effusion on palpation with a patella tap. So a patella tap, you're essentially pressing down on the patella, and if there is an effusion that has lifted the patella away from the distal femur, then when you're pressing on the patella, it will push down sort of through the effusion, and as it hits the bone underneath, it will knock against it, and you'll feel a distinct tap as you hit a hard surface, and you only get that when the patella has been lifted up because of the effusion. His range of movement is very difficult to assess, but probably I could only really get it about 5 to 10 degrees before he sort of asked me to stop because it was very, very tender. But I think it was slightly restricted by the effusion as well. He was also a little bit tachycardic in the emergency department, and he was actually pyrexial at 38.1.
Okay, yeah. And so what's your working diagnosis?
So the thing that I'm most worried about for him would be a septic arthritis of the knee. You'd also want to consider a crystal arthropathy, so gout or a pseudo gout. Other things that could cause sort of sudden onset joint effusions, you'd think about maybe a hemarthrosis, but there's no trauma.
Has he had any recent upper respiratory tract illnesses or any chest infections recently?
Not that he reported, no.
What are his risk factors for septic arthritis?
So the main risk factor for him would be the diabetes. He's not had any previous surgery or trauma to this knee, so there's sort of no evidence of direct inoculation, but he is slightly immunosuppressed due to his diabetes, or he's high risk of developing a septic arthritis because of that.
Why is septic arthritis a problem? Why are we worried about it?
So when you get an infection in a joint, it causes destruction of the cartilage, which can cause degenerative effects from that.
You can get very sick, systemically unwell, and you may require ITU admission, and it can be fatal. Fine. So what investigations are we going to do?
So we've already done some OBS, which show he's tachycardic and pyrexial. We want routine bloods on him to look at his white cells and CRP. When you're concerned that somebody might have sepsis, then you want to think about your sepsis 6, which is the give 3 and take 3. So things that you want to give would be oxygen, IV fluids and antibiotics, and the things that you would take would be a lactate with a VBG, blood cultures, and then you'd also want to measure urine output. And that, of course, you would want to do once you've aspirated the knee, because you'd want to get your knee aspirate before starting antibiotics, ideally, unless the patient is so septic that can't wait. So I'd probably want to get x-rays first, just to make sure that there's not a fracture, that he hasn't had a knee replacement that he's forgotten about. And
you might see a scar as well. So if there are any unexplained scars, then you'd be wanting to know the history of those, and that can be quite difficult if someone has got memory issues and they can't remember exactly what has happened. You want to get an X-ray to give yourself a better idea of what's going on. You mentioned gout and pseudo gout. So what clues would you be looking for on an X-ray?
So in gout, you can see chondrocalcinosis, just sort of calcification.
Yeah. You get some calcification around the meniscal layers.
And then the key investigation that we want to do in this is to aspirate the knee, so you can see what the fluid's like and send that off and get more information.
Is there any other way of diagnosing a septic arthritis other than aspirating the knee? An MRI will show you if there's an effusion in the knee. It won't tell you if it's an organism. The only way of knowing is by taking a sample.
So for aspirating a knee, before you start, you just want to make sure that there are no contraindications. So the major things that you want to think about would be an overlying cellulitis, then you wouldn't want to stick a needle in because that could seed an infection into the joint if there wasn't already one. Coagulopathies, or if they're on things like NOACs, because you may cause a hemarthrosis. And also if they've had a knee replacement, you still want to aspirate, but you'd want it to be under sterile conditions. So you'd want it to be in an operating theatre with laminar flow and fully scrubbed, because if there's not an infection and you introduce one, then
that's potentially disastrous, isn't it?
Yeah, absolutely. So if you're happy there are none of those contraindications, knee aspiration is performed under aseptic conditions. I feel for the upper outermost edge of the patella, I sort of go another centimetre lateral and centimetre proximal. And that's the point that I would insert the needle. And you're sort of aiming behind the patella. So you sort of aim at a bit of a diagonal. And what you do is as you insert the needle, if you're aspirating on the syringe as you go, then as soon as you get into the joint space, you'll get a joint aspirate in your syringe, which tells you that you're in the right place. So for a knee aspiration, you have to use a large gauge needle because the fluid can also often be very viscous. So if you use a small needle, then when you're aspirating, it's actually very difficult to get any fluid out. When you aspirate a knee, you always want to aspirate to dryness. So if you get some fluid out, although you only need a few mils for the sample that you need to send off for MCNS and crystals, you want to make sure that you're taking away as much of that fluid as you can, because that's that fluid with the bugs in there. Then by aspirating all of it, then you're reducing the proteolytic enzymes. That's what's going to damage the cartilage, and also if there's lots of bacterial load as well. So you always want to make sure that you take as much out as you can.
And also it's much more comfortable once you've had that large effusion aspirated. You take the needle out and then put it back in again, or do you leave the needle in and just keep taking fluid off?
So once you know that your needle's in the correct position, you leave the needle where it is, and you just sort of have to gently twist your syringe off, and then you can attach a new syringe, draw off more fluid, and then you can, if you take several syringes with you, you can keep doing that until you get to dryness. So sometimes you can take off around sort of 60 mils off of a knee joint or more.
Yeah, absolutely. So if you put your index finger and your thumb over the distal part of the thigh to push all the fluid down once you've taken your initial hit. The other thing I'd say is just that I always say to people when they're aspirating a knee is that from what patients have told me, the most painful bit is going through the skin. So the bit not to hesitate over is not to go slowly through the skin, get into the skin and then into the joint, because that's the bit that makes them jump the most, is when it's very slow going through the skin, because it's incredibly sensitive with a tense effusion like that. There are different areas where you can aspirate. You can go superolateral here, you can go direct medial, you can go straight in next to the patellar tendon. You want to avoid any area of skin change, or if they've got eczema or psoriasis, again, to avoid those sort of areas.
When you aspirate any joint, you always want to send off 2 samples. So they'll be in a white top standard tube for MCNS and also gram stain, and the other tube will be sent for crystal analysis to look for gout or pseudo gout. They look at it under polarized light, and in gout you get negatively birefringent crystals, and in pseudo gout positively birefringent.
Does that look to you like normal joint fluid?
No, so that's cloudy and looks like pus, so it's quite concerning to aspirate that. Normally the synovial fluid it usually has a yellowish tinge, but it's usually clear. If you held up a newspaper behind your sample tube, you should still be able to make out the letters of the newspaper text. But in this case, obviously you can't see through that at all. Just in terms of the practicalities of that, in some trusts you do just need to make sure that you've spoken to the microbiology department out of hours if you're sending them a sample, because they won't routinely be checking for urgent samples. But obviously, this is something that you would need to know the result of as soon as possible.
And what are we going to do with the patient in the meantime?
So now that we've got an aspirate from the knee and we've got a sample to send to microbiology, given the fact that this man is pyrexial and a little bit tachycardic, I think I would want to start him on broad spectrum antibiotics fairly quickly and await sensitivities for that result. I'd also want to be escalating it to my seniors. Having seen that fluid come out, got a fairly high suspicion that he does have septic arthritis. He's diabetic, so on his bloods you'd want to check his HbA1c, arterial blood glucose levels on the ward, and make sure that his sugars aren't running really high, and that he might also need a sliding scale just to control his sugars perioperatively.
And washing out his knees, so there's two ways of doing it. There is some controversy over whether you do it open or arthroscopically. The controversy mainly is that some people argue that you can force the bugs further into the knee by doing that, and by doing it open, it's a better washout.
If you were doing an arthroscopic washout, you'd make one incision down here and the one up here.
The idea that would be that you would wash fluid from one side, so either coming in this way and a sucker taking it out that way. You'd have another incision here and have your inflow by one arrow and the outflow by the second arrow, and that just allows the fluid to circulate, and the idea being that once it comes back completely clear, where the joint's been washed out. Alternatively, you can make an incision so above the patella, going down into the joint, and you can put in an irrigator, which is a means of delivering high volumes at low delivery rates through the knee. It's then possible you can then make an exit portal as well. You want at least 3 or 4 litres to go through the knee until it was completely clear.
When you're on call, you probably see 1 or 2 swollen knees a week. I'd say the vast majority of them tend to be a crystal arthropathy of some description, but when people do come in with a septic knee, they are often fairly unwell, and it is something that you need to be able to deal with sort of quickly and confidently.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.